When we normally look at a medical diagnosis or a treatment plan, we really tend to expect this engineering level precision, right?
Oh,
It's like you break a bone, an x-ray shows you the exact jagged white line, a cast goes on, and the biological math just, it adds up.
it's very binary.
Exactly. It's incredibly binary, and honestly, I think we take a lot of comfort in that visibility. But stepping into the arena of regenerative medicine, and specifically when we're looking at treatments for vaginal health today, that comforting binary framework just completely shatters.
It really does. The whole landscape shifts from like a simple mechanical repair to this very complex biological negotiation.
Right.
Because people often casually refer to therapies like vaginal platelet-rich plasma or, PRP as just a simple blood draw followed by an injection.
Like it's just moving fluid from point A to point B.
Exactly. But the reality happening inside the clinical hardware is vastly more complex. I mean, the actual physics operating inside the centrifuge, the machine dictating the separation of your blood layers, literally programs the biological payload that enters your tissue.
And that is exactly our mission for today's deep dive. We are exploring the fascinating microscopic mechanics behind PRP therapies for vaginal health, focusing entirely on how the exact way a patient's blood is spun drastically alters the regenerative yield.
Yeah, the centrifuge is everything.
It really is. So we're looking at single spin versus double spin protocols and how those G-forces dictate the growth factors delivered to the tissue. And to map this all out, we are pulling from a massive stack of clinical trial records, medical device engineering evaluations for advanced systems like the XL and Dr. PRP devices, and peer-reviewed gynecological studies.
It's a lot of dense material, but it's fascinating.
It is. Okay, let's unpack this. Before we get into the whole debate over centrifuge speeds, we have to look at the payload itself, right?
Right.
We're hunting for alpha granules inside the platelets.
Yeah, and those alpha granules are really the absolute core of regenerative medicine. They are these little storage vesicles packed with the growth factors that direct cellular behavior.
The actual instructions for the cells.
Exactly. In standard whole blood, these factors are circulating at baseline levels, just doing routine maintenance. But when you process that blood and concentrate the platelets, the jump in these regenerative molecules is staggering.
How staggering are we talking?
Well, the data from our sources shows vascular endothelial growth factor, or VEGF, jumping from about 155 picograms per milliliter in whole blood to nearly 995 in properly spun PRP.
Wow. Which is a massive, almost seven-fold leap.
It's huge.
And VEGF is the primary driver for angiogenesis, right?
Yes, new blood vessel formation.
So when you introduce that level of VEGF into the vaginal wall, you aren't just hydrating the tissue. You are basically commanding the body to construct a completely new network of capillaries.
Right, which restores the blood supply. And that fundamentally reverses the physiological deficits we see in things like genitourinary syndrome of menopause or GSM.
It rebuilds the infrastructure from the ground up.
It does. And alongside VEGF, you have transforming growth factor beta 1. The studies show that jumping from roughly 35 to over 120 picograms per milliliter.
And TGF-beta1 is crucial because it specifically modulates the production of collagen type 3, doesn't it?
Exactly. In vaginal tissue, you don't just want any collagen. You don't want rigid scar tissue. You need elastic, resilient tissue.
Right, for obvious reasons.
Yeah. And TGF-beta1 directs the local fibroblasts to produce that specific elastic matrix.
Reading through these trials, one detail really stood out to me about the specificity of this extraction.
Oh, yeah. Which one?
So, platelet-derived growth factor and epidermal growth factor see these huge spikes, but insulin-like growth factor 1, IGF-1, didn't actually increase in one of the primary studies.
Ah, yeah.
It shows that the centrifuge isn't just a volume dial that turns everything up equally,
No, not at all. It acts much more like a targeted biological filter. Because IGF-1 is primarily circulating freely in the plasma rather than being densely packed inside the platelet alpha granules.
Oh, I see.
So spinning down the platelets doesn't artificially inflate its numbers the way it does with VEGF or TGF-beta. It highlights that we are extracting a highly specific cellular profile.
Not just a concentrated soup.
Exactly. Not just a soup.
I always like to visualize it this way. Platelets are essentially like microscopic paramedics circulating in your blood, but the centrifuge protocol determines exactly what kind of medical kit they are allowed to bring to the injury site.
That's a great analogy. And for submucosal vaginal tissue, you need a medical kit tailored for very specific architectural repair.
Because women experiencing GSM are dealing with a profound loss of tissue elasticity, right?
Yes, and neuronal degradation causing decreased sensitivity, plus a compromised vascular bed that prevents natural engorgement and lubrication.
So when those concentrated alpha granules degranulate in that space, they release nerve growth factor to repair neuronal pathways, alongside the VEGF and TGF-beta.
Right, but the critical question is how we best extract those paramedics from the bloodstream in the first place.
Okay, so let's get into the mechanics of that. Historically, the industry standard started with the single spin.
Yes.
Because it's fast, it requires less specialized equipment, and it's often referred to as a soft spin.
Right, a soft spin. We're talking about putting the blood in a centrifuge for maybe 4 minutes at 3,400 RPM or 10 minutes at 2,000 RPM.
Which creates a gravitational barrier that yields a platelet concentration about 2 to 4 times higher than baseline.
Yeah, and that lower G-force has a very distinct biological advantage that goes way beyond just saving time for the doctor.
What's the biological advantage?
It allows for the creation of fluid platelet-rich fibrin, or FPRF, because you aren't subjecting the cells to massive mechanical trauma and you aren't chemically altering the plasma, the fibrinogen remains largely intact.
So when it's re-injected, it polymerizes into this three-dimensional gel-like network inside the tissue.
Exactly.
It essentially weaves a biological net that traps the growth factors in place, right?
Yes, exactly that.
So instead of the payload just diffusing rapidly into the surrounding tissue or being carried away by the bloodstream, this FPRF matrix provides a slow, continuous release for up to 10 days.
10 straight days of localized cellular signaling.
Wow.
Yeah, and that sustained release can be incredibly beneficial for chronic conditions like GSM, where the tissue really requires prolonged stimulation to remodel effectively.
So the soft spin preserves the structural integrity of the cells and creates a sustained delivery system.
Exactly.
Okay, I have to push back here.
Sure.
If a single spin is faster for the clinician, causes less trauma to the living cells, and creates this brilliant 3D matrix for a 10-day slow-release healing cascade,
Sure.
why isn't it the universal standard?
That's the million-dollar question.
Because, reading the literature, there seems to be this intense drive toward massive concentration numbers, which requires moving away from the simple single spin. Is it just an obsession with higher numbers?
What's fascinating here is that the simplicity of the single spin creates a very specific set of biological blind spots, largely due to the physical properties of platelets themselves.
Okay, what kind of blind spots?
Well, many standard single spin systems use a synthetic separation gel inside the tube. Under centrifugation, this gel forms a physical barrier based purely on density.
Right.
But platelets are incredibly heterogeneous. They do not all weigh the same.
But that they come in different ages and sizes, right? Like you have young, newly formed reticulated platelets that are larger and denser, and then older platelets that are lighter.
Precisely. And the heavy, younger platelets are actually the most biologically active. They carry a much denser payload of mRNA and growth factors.
Oh, I see where this is going.
Right. Because they are heavier, a generic density-based gel barrier will often trap them down in the red blood cell layer.
So you might successfully separate the plasma, but you've left your best, most capable paramedics trapped behind the wall.
Exactly. And the other major hurdle for a single spin, particularly in gynecology, is the leukocyte count.
The white blood cells.
Yeah. A standard single spin system tends to retain a high concentration of leukocytes, which are notoriously pro-inflammatory.
Now, if you are treating, say, a torn patellar tendon, injecting a leukocyte-rich PRP might actually be desirable. Right?
Oh, absolutely. That acute burst of inflammation can reboot a stalled healing cascade in really tough avascular tissue.
But the vaginal submucosa is highly vascular and incredibly sensitive.
Very sensitive. Introducing a massive dose of pro-inflammatory cytokines via trapped leukocytes can cause significant unnecessary swelling, localized pain, and just a highly uncomfortable recovery for the patient.
Which totally defeats the purpose if the patient is coming in to resolve intimate pain and discomfort in the first place.
Exactly. It's counterproductive.
So to filter out those leukocytes and capture those heavy platelets, the bioengineering shifted to the double spin protocol.
Yes. And this is where we see specialized kits like the Dr. PRP system coming into play. The double spin protocol is really an exercise in absolute fluid precision. It physically forces the separation that a single spin just attempts with a gel.
Okay, walk us through it.
It starts with a soft spin to get the red blood cells out of the way. The clinician then manually extracts that plasma, transfers it to a sterile secondary tube, and subjects it to a hard spin.
And a hard spin is no joke. I was looking at the G-force metrics on these devices. We are talking about subjecting the blood to 1,500 Gs for 15 straight minutes.
It's intense.
That amount of centrifugal force must literally crush the platelets down to the microscopic floor of the tube.
That's exactly what it does. It creates what we call a dense platelet pellet. The force is so immense that the platelets, regardless of whether they are light and old or heavy and young, are driven to the absolute bottom.
So they all get captured.
Right. And the fluid left sitting above them is platelet-poor plasma, or PPP. It is almost entirely devoid of cellular material.
Ah, I see.
So the clinician draws off that excess fluid, leaving only the dense pellet, which is then resuspended in just a tiny fraction of plasma.
So if I'm visualizing this, a single spin is like using a metal sieve to get the big chunks out of your coffee. It does the job, but it's kind of cloudy.
Yeah, good analogy.
But a double spin is like using the sieve and then running the liquid through an ultrafine paper filter, distilling it down to the absolute purest, highest octane espresso shot of platelets possible.
That is a perfect way to look at it. And that concentrated espresso shot yields a massive 5 to 8 times baseline platelet concentration.
5 to 8 times.
Yeah. And crucially, because of the manual extraction process between the spins, it allows the clinician to leave the buffy coat, the layer, housing the white blood cells behind entirely.
Which creates leukocyte-poor PRP.
Yes. So you deliver a massive concentrated dose of VEGF and TGF-beta without triggering a localized inflammatory immune response.
Okay, if I'm listening to this as a prospective patient, double spin sounds like the undisputed winner.
It does sound like it.
I mean, you get pure concentration, you capture the heavy platelets, and you eliminate the inflammatory white blood cells. Case closed, right?
Whoa.
But the device engineering reports throw a massive wrench into this conclusion.
They really do.
Because it turns out the number of spins isn't the only variable. The actual physical geometry of the centrifuge hardware completely rewrites the rules of cellular survival.
Yeah, the physical shape of the rotor, the arm that holds the tubes inside the machine, is arguably just as important as the G-force.
How so?
Well, a lot of basic clinical centrifuges utilize fixed-angle rotors. The tubes sit in a permanent 45-degree slant.
Okay.
When you spin fluid at 1,500 Gs on an angle, the cellular material doesn't travel straight down. The physics of the spin forces the fragile platelets to slam horizontally into the plastic sidewall of the tube before sliding down to the bottom.
Which introduces massive shear stress.
Massive.
You are taking living cells that are highly sensitive to mechanical disruption and basically dragging them down a plastic wall under 1,500 times the force of gravity.
Exactly. It prematurely activates them, or worse, completely destroys the cell membrane before it ever even reaches a syringe.
That's wild. So all that effort to concentrate them just destroys them.
Potentially, yeah. The more advanced devices utilize a horizontal or swing-out rotor.
Like a carnival ride.
Yeah, exactly.
Yeah.
When the machine powers up, the centrifuge buckets physically swing outward to a perfect 90-degree horizontal angle.
So the G-force vector pushes the cells straight down through the fluid column.
Exactly. It creates perfectly flat, uniform layer separation based on density. It gently pushes the platelets to the bottom without ever crushing them against the sidewall.
And this is where the technology is advancing so rapidly that the old rule of single spin equals low concentration is actually becoming obsolete, right?
Very much so.
Because looking at the engineering data for advanced single spin systems, like the XL 60 milliliter device, they are leveraging proprietary separation algorithms and highly specific chamber geometries to just bypass the need for a double spin entirely.
Yeah, it's incredible. By utilizing finely tuned optical sensors and mathematically modeled acceleration curves, these next-generation single-spin devices are achieving 8-fold baseline concentrations and capturing up to 83% of the available platelets in a single run.
So they are matching the sheer concentration power of a manual double spin, but doing it in a fraction of the time.
Yes. Plus, you eliminate the contamination risk. The clinician doesn't have to open the system halfway through to manually pipette the plasma into a new tube.
Right, because it happens entirely within a closed, sterile loop.
It gives you the leukocyte-poor purity of a double spin with the cellular preservation of a soft spin.
Best of both worlds.
Exactly.
Right.
However, even if a clinic has invested in a top-tier swing-out centrifuge with automated optical sensors, biology still dictates the absolute ceiling of the therapy.
Because the machinery can only extract what your body provides.
Bingo.
And here's where it gets really interesting. The human variables. When evaluating vaginal PRP therapies, the patient's own endocrinology plays a massive role in the outcome, doesn't it?
A massive role. The trials demonstrate significant sex-based differences in blood composition.
Right, like male PRP generally yields higher baseline levels of certain growth factors.
Yes, but female platelets exhibit significantly greater aggregation and activation capabilities.
They respond much more aggressively to the regenerative signaling.
They do, and the underlying cellular mechanism for that difference is estradiol.
Estrogen.
Yeah. Estrogen isn't just a reproductive hormone, it fundamentally modulates vascular and cellular function. Platelets actually have estrogen receptors right on their surface membranes.
I had no idea.
Yeah, when estradiol binds to these receptors, it alters the intracellular calcium mobilization pathways, making the platelets highly reactive.
So the hormone literally primes the platelets. It lowers their threshold for activation, so they release their growth factors more readily when they encounter damaged tissue.
Exactly.
But if a woman is seeking this therapy for genitourinary syndrome of menopause, her systemic estrogen levels have inherently plummeted.
Right.
Her baseline blood chemistry has fundamentally shifted. So does that mean the centrifuge protocol has to compensate or work harder to extract a viable yield compared to a premenopausal patient?
If we connect this to the bigger picture, a postmenopausal environment requires a highly optimized protocol.
Because of that estrogen drop.
Yeah, the drop in estradiol changes leukocyte composition and blunts that natural platelet hyperreactivity.
Makes sense.
You cannot apply a generic, one-size-fits-all clinical protocol to a postmenopausal patient and expect optimal tissue regeneration. The baseline biological material is different.
Right, which means ensuring the highest possible capture of viable heavy platelets without the inflammatory leukocytes becomes even more critical to cross the therapeutic threshold.
Absolutely critical.
So what does this all mean? If you are listening to this and looking at your own treatment options or supporting someone considering a regenerative vaginal procedure, whether it's marketed as an O-shot or under another clinical name, it is absolutely vital to recognize that PRP is not a monolithic, standardized drug.
It is not aspirin.
Right. It is a highly variable biological product manufactured in real time in the clinic room.
Yes, the regenerative potential of your treatment is entirely dependent on the hardware geometry, whether they use fixed angle or swing-out rotors, the fluid dynamics of their single or double spin protocols.
And how well the clinician adapts those variables to your specific hormonal status.
Exactly. Asking your provider about the specifics of their centrifuge and their target platelet yields is entirely appropriate.
Honestly, it's the only way to know if you are getting a therapy designed for your specific tissue needs.
Agreed.
Well, before we wrap up, we want to leave you with a final provocative thought to mull over, based on some of the clinical debates we uncovered today.
This is a really interesting one.
So we know that platelets must be activated to release their growth factors, right? And many clinics use exogenous chemical activation. They manually add calcium chloride or bovine thrombin to the syringe right before injection.
Which forces a massive immediate degranulation, releasing up to 70% of the growth factors within just 10 minutes.
10 minutes. But the emerging counter-argument asks whether forcing that biological timeline is actually detrimental.
Yeah, what if the absence of chemical activation is superior?
Right, like relying purely on the endogenous natural microinjuries caused by the physical needle entering the tissue to slowly activate the platelets via natural collagen exposure.
Which might create a timeline that aligns much better with how the body actually builds new vascular networks.
It is really the cutting edge of the debate in regenerative medicine right now. Does tissue heal better when we artificially flood the zone, or when we deliver the raw materials and let the body's natural signaling dictate the pace?
It's the biological dial.
Yeah. And the speed of activation, the G-force of the centrifuge, the density of the platelets, they are all just different notches on that dial. You just have to make sure your provider knows exactly how to tune it.